Okay, guys, this lecture is about the anatomy and physiology of the functions of the heart. Now, I'm not going to go through all the physical aspects of the heart. You guys probably learned that in A&P, so I'm not going to waste your time going through it. But I am going to tell you that you need to know them, okay? It's going to be hard if you don't know where the mitral valve is located, and I say if it's regurgitation, where is it regurgitating to? If you don't know that it's on the left side of the heart between the atrium and the ventricle, then you're not going to know that it's going to back up into the atrium. So, therefore, please, if you don't know your anatomy of the heart, please know them because it's really going to help you. Okay, cardiac anatomy terms, we have the atria and the ventricles, which we are pretty well aware of, right? Endocardium, myocardium, epicardium, pericardium, valves, arteries, veins, and capillaries. That's a little quick review. And here's the wonderful heart. And of course, we're not going to have to know all the little, like the fossa ovalis or the tribeca carni. We're not going to need to know those. I'm looking at the bigger aspects of the heart. Okay, the pericardium is a double-layered fibrous membrane surrounding the heart. Okay, there's two layers. There's the parietal and the visceral. And we're going to need to know the pericardium because we're going to look at different aspects like the pericarditis. Now, if you don't know exactly what the pericardium is, or that it's two different layers, then you're not going to quite understand what goes on with pericarditis. Okay, there's a space between the parietal and the visceral. Okay, and within that space is pericardial fluid. It lubricates and cushions the heart. Now, the problem with this, we're going to find out, it can become infected, can have pus, it can cause some issues for us patients. Okay, please know the circulation of the heart. Where exactly does it go? Where does it begin and what happens when it goes to the lungs and back to the heart? Okay, please know this. Like I said, I'm not going to spend much time on it because you learn this in A&P. Just get out your A&P or get online and look at it. But remember, the right side of the heart has the unoxygenated blood. It goes to the lungs and it comes back, and with the oxygenated blood comes into the left side and it gets pumped out. Cardiac cycle, the systole is contraction, and that's the volume and the ventricles are released. Okay, that means that that's where the contraction happens in the left ventricle. Diastole is a relaxation. This is when preload happens. Okay, the volume of the ventricles are increased. Stroke volume is how much of that blood is sent out. Okay, average is about 70 milliliters per beat in average adults. Of course, that can be increased or decreased depending on what's going on with the patient. Okay, what the ejection fraction is the fraction of percent of blood that's ejected with each contraction. So when you're talking about the stroke volume, we're talking about the amount of blood that is pushed out of the heart from the ventricle. What we're looking at with the ejection fraction is how much of that blood still remains into the heart. If it's below 50%, we're talking about our patients being in heart failure. Okay, we've had patients as low as 15%. I think the lowest I had was 10%. Okay, there's things that we're going to do, and we're going to learn about those things of what we do when patients' ejection fraction is low. The way we figure out the ejection fraction is whenever we do an echocardiogram, which we're going to learn about echocardiograms later. But that's a main reason why we do the echocardiogram, especially if somebody is just had a heart attack or we suspect that they're in CHF. Okay, cardiac output. It's the amount of blood that is put into the systemic and pulmonary system in 1 minute. Cardiac output equals the heart rate times the stroke volume. Okay, so in the next slide, we're going to see increased heart rate increases the cardiac output even without the increased stroke volume. Makes sense, right? So if your heart rate's elevated, okay, it can increase the cardiac output because your heart is pumping so fast, and this, whoops, I didn't mean to underline that, even without increased stroke volume. So basically your heart's taking care of putting out all that blood in 1 minute. But if your heart's going too fast, okay, so your heart's bumping really fast, but it's not allowing for the ventricles to fill, then you're going to have decreased cardiac output. Okay, so for example, say you're hemorrhaging, say your patient's hemorrhaging, you're going to have an increased heart rate, but the stroke volume is not going to be there. So therefore, it's going to be decreased cardiac output. On the same aspect, if you have a high heart rate because you're in heart failure, your heart's not able to pump out that stroke volume, right? It's not going to have a good ejection fraction. It's going to decrease the cardiac output for that patient. Okay, does that make sense? On the other hand, with bradycardia, what you could have is a decreased cardiac output because the heart rate's so slow. So you have an elevated, you have a decreased heart rate, but your stroke volume's the same, but the cardiac output's going to be so low. Okay, remember, it's the amount of blood that's going into the system in 1 minute, not necessarily out of the heart, but into the system. Okay, how do we assess cardiac output in our patients? And this is the time of day that I ask you this question in class. So imagine you're sitting in those desks, and I ask, and everybody kind of just looks at me. So we'll just do that for a second. Just virtual being in our desks. So how would we look at and assess cardiac output? Okay, if you're walking into a room in a patient's room, you're walking into a patient's room and you ask them a question. Are they lethargic? That could be showing of low cardiac output, right? Maybe they are a little confused. That could be one. So let's think about this. Go back to Sharon's class and you're doing your head to toe. What would you see in their face? Would you see possibly cyanosis? Maybe they're a little grayish, pale, okay? Then we go down and we can, what if we listen to their lungs? Would we hear anything different? We could. If they're in heart failure, we might hear some crackles. That would show some decrease in cardiac output, right? What about going down and feeling their heart rate? If we're palpating their pulses, would we feel a bounding pulse or would we feel a weak pulse? What about capillary refill? Would they have less than 3-second capillary refill? Would their hands be cold? Okay, these are all signs of low cardiac output. Okay, what about even if we're going down even further? In their legs, would they be swollen? Possibly, because of decreased cardiac output, right? Pedal pulses being slow, weak, or are they bounding? I would imagine they would be weak if they had decreased cardiac output. Okay, the biggest one that we're going to know about decreased cardiac output is the fact that their urine output. Okay, if they have a decreased cardiac output, that means their kidneys are not being perfused. If their kidneys aren't being perfused, that means they're not making urine, and that makes a decrease in urine output. One of the ways we can tell a patient is hemorrhaging, one of the first signs, is that they are actually their urine output. That's why it's critical in patients that are post-op, even your more serious, but not so much, hysterectomies. If they've had coronary bypass, we look at their urine to make sure that their heart is still working and they're not hemorrhaging. Okay, that they're still having cardiac output. Controls of the heart, we have the sympathetic and the parasympathetic. Sympathetic, increased heart rate, more forceful contraction, vasoconstriction. This is your fight or flight aspect. Okay, that if you're going for a fight, you're going to have increased heart rate. Your body's going to react to that, and then you're going to vasoconstrict. When you vasoconstrict, that means that you're actually you will have less, your body's not going to have to urinate because it's not worried about that right now. It's worried about saving your life. Okay. Parasympathetic is slowing of the heart rate, decreased strength of contraction, vasodilation. That's when you're more relaxed, okay? You don't need that fighting instinct, okay? It's part of the vagus nerve. Now, the vagus nerve is a really kind of cool nerve. It's one of the larger nerves of your body. And what we'll see is that the vagus nerve really helps in times of a patient is in SVT, okay, which is supraventricular tachycardia, okay. We can actually use that vagus nerve to get them to slow and to recapture the SA node. Actually, if you talk to a coroner, a lot of people are found on their toilet because of the vagus nerve. What happens is they sit there and they bear down to have a bowel movement, and it slows down the heart rate so much that they actually go into a dysrhythmia. I swear, I don't swear, but if you've ever listened to anything about Elvis Presley and the reason that he passed away, even though I think it was on E or maybe A&E, that he's not really dead, he's like in Venezuela or Brazil or somewhere down there. What happened, they said it was because of the drugs. Well, yes and no, it was because of the drugs. What happened is that he was taking all those medications. It slowed down his heart rate, or I'm sorry, slowed down everything. He ended up with a megacolon. What a megacolon is when you don't have a regular bowel movement, it just kind of like sits there and kind of gives you an obstruction of sorts, but your intestines gets bigger. It kind of forms around that. And what he was doing, well, at 2 or 3 o'clock in the morning, he went to go and take a poo, and he was trying to have a bowel movement, and within that bowel movement, he stimulated that vagus nerve, which caused him to go into a dysrhythmia. It slows your heart rate down. We can actually see people in telemetry when they're having a bowel movement, their heart rate will slow as when they're on the toilet. I'm telling you, when you're in the hospital, we see everything and we know everything, and that's one of the things we know, okay? Is when you're having a bowel movement. It's kind of creepy, but it's true. That's why we give people stool softeners on the cardiac step-down unit. So when they do have a bowel movement, they don't have to push as hard and have that vagus nerve respond. Anyway, back to Elvis. He was trying to have a bowel movement. He was unable to have a bowel movement. He stimulated that vagus nerve, and it caused him to go into dysrhythmia. Of course, he was by himself. That dysrhythmia turned into VTAC, probably VBIB, and he passed away. So now you know the truth about Elvis. Contractility, it's the inherent capability of cardiac muscles fibers to shorten. Okay, poor contractility does not allow the blood to go forward. Increased contractility may overstress the heart. Okay, it's a muscle. So if we overstress it, guess what's going to happen? Sooner or later, it's going to fail. Okay, when we're talking about preload, we're talking about the stretching of the cardiac muscle. Okay, so it's how much blood we can actually get into the ventricles at a set amount of time. Starling's law states that the greater the stretch, the more forceful the contraction. So if you're able to, if it stretches a little bit, then that ventricles are able to push out that blood. The problem with that is too much of a good thing is a bad thing. So overstretching the fibers can also create ineffective contraction. Think about a balloon. Okay, the first time you blow into that balloon, it's hard to blow in, right? Some people have a hard time getting a balloon started. But after you let that air out and you blow it again, it gets easier and easier because the fibers of that plastic is stretched. Well, that's exactly with the heart. So if we overstretch those fibers, it's not going to be able to contract as well. So somebody that we put in congestive heart failure, maybe we overload them with fluids. It's hard for that heart to get back, okay, into a good spot, let's say, a good place for it to be a forceful contraction again. Okay. On the same aspect, too little of a volume or decreased venous return results in decreased preload. So think of it this way. If you have when I think of preload, I think of venous blood, right? because it's the blood that's coming back into the heart. Venous blood is dirty blood. It's no good for us, okay, because it doesn't have the oxygen that we need to survive. And when a patient is vasodilated, that decreases the preload into the heart. Does that make sense? Because what we need to increase the preload is vasoconstriction, to push that blood into the heart. Vasodilation actually does not push the blood into the heart. It allows blood to leave the heart, but not to push the blood into the heart. We'll get a little bit more into that further down. Okay, afterload is the force that the heart has to go against to get the blood out of the ventricles. The lungs, or the right ventricle, not so hard, right? It's just going into the lungs. It's right near the heart, not a big deal. The left, though, has a whole lot of issues because it has all that blood that it needs to push out to the rest of the system. That's why your left side and your heart bigger on the left side versus the right side. Okay, as the afterload increases, so does resistance. So if you have a medication that vasoconstricts, it's going to cause an increased afterload. If you have a medication like nitro that vasodilates, it's going to decrease afterload. Okay, as workload increases, so if you have a vasoconstricted medication, the myocardial oxygen consumption increases. So that means the oxygen that needs to get to the heart for the heart to work also increases. And we're going to talk about myocardial oxygen needs, okay? Because when we have angina or we're having an MI, that plays a huge factor of what's going on. But for this, as your workload increases, okay, we need to increase the oxygen going to the heart. Cardiac index, really don't play much about this, I'll be honest. Cardiac output adjusted to the patient's BSA, calculated by cardiac output divided by BSA. Normal ranges in 2.5 to 4.2. That's just a FYI. Cardiac cycle, each cardiac cell possesses the ability to self-excite, and the control is exercised by SA and AV nodes. Okay, electrical system of the heart. The SA node is your, I'm not drawing really good there, sorry. The SA node is your pacemaker of the heart. Okay, that's the one who sets the tone of the heart. And if that SA node doesn't work, then we go into the AV node. If that AV node doesn't work, then we're going to go down to the Purkinje fibers. But right now we're paying attention to the SA node, especially with a lot of our arrhythmias that we're going to be talking about. Okay, electrical action potential depolarizes cells, causes contraction. The repolarization of the cell is the cell at rest. An absolute refractory period means that no matter what, the nerve cannot be stimulated to contract, no matter what. A relative refractory period is when they're able to be recovered and there is a potential for that nerve to be stimulated. Okay, and I believe this is the end of this lecture. I hope you found it tolerable, and I guess I'll see you next lecture. Thank you. Goodbye.